Good morning, all. So we were on the adrenergic drugs, and among the adrenergic drugs, in the last class we did about the adrenaline, noradrenaline, and the dopamine. So adrenaline being the prototype drug in the adrenergic system or adrenergic agent, whereas the noradrenaline being the most common or the most important neurotransmitter that is released from the body when sympathetic system is being activated. So adrenaline is the neurotransmitter, as well as they are available as the drug, and they are responsible for stimulation of all the adrenergic receptors. So all the alpha-1 receptor subtypes and all the beta-1 receptor subtypes. Whereas non-adrenaline, it is not associated with the stimulation of beta-2 receptors. So it only stimulates the alpha-1, alpha-2, and beta-1 receptors, nor the beta-2 receptors. And due to this reason, so being the stimulation of the beta-2 receptors, it doesn't cause the vasodilatation, and hence it only stimulates the alpha-1 receptors, beta-1 and alpha-2 receptors. It causes the vasoconstriction, and hence the vasoconstrictive effect of this noradrenaline, or the pressure effect of this noradrenaline, is more than that of the adrenaline, because adrenaline is associated with the stimulation of both alpha-1, which causes the vasoconstriction, and beta-2, which is responsible for the vasodilatation of the blood vessels, whereas non-adrenaline is only responsible for vasoconstriction, and hence the pressure as action of this noradrenaline is more than that of the adrenaline. And dopamine, so dopamine has its dose-dependent action, so it's responsible for stimulation of dopamine receptors, alpha receptors, as well as the beta receptors, and it is the dose dependent. So on the low dose, it stimulates the dopamine receptors. The intermediate dose, it stimulates the beta receptors, and in high dose, it's responsible for stimulation of the alpha receptors. So these dopamine, adrenaline, and noradrenaline all are the endogenous catecholamines. They are synthesized, they are released within the body, and we are going towards, actually this is not included in your syllabus, so we'll have brief information about these drugs. So isoprenaline, so it is not the endogenous catecholamines, it is not secreted from the body, it's not released from the body. So it is the synthetic catecholamine and is available as the drug. And it is responsible for stimulation of beta receptors, both beta-1 as well as the beta-2 receptors. However, it has very negligible action on the alpha receptors. And since it causes the stimulation of the beta receptors, so it causes the intense stimulation of the heart. That means it increases the heart rate, it increases the cardiac contractility, and it increases the cardiac output from the heart. And due to stimulation of the beta-2 receptors, so it causes the fall in diastolic pressure, and it also causes the bronchodilation. So beta-2 receptors are present on the larger blood vessels, and when the stimulation of these larger blood vessels is done, so there is the vasodilatation. So due to the vasodilatation, there is fall in blood pressure. So this will lead to the fall in diastolic pressure or diastolic blood pressure. And beta-2 receptors are also present in the bronchioles of the lungs, and stimulation of this beta-2 receptors will cause the bronchodilation. So isoprenaline is a synthetic catecholamine which is responsible for stimulating beta-1 and beta-2 receptors. So continuing with the synthetic catecholamine, so another important synthetic catecholamine is the dobutamine, and it is a derivative of the dopamine, and it acts on the both alpha as well as the beta receptors, but most importantly, it stimulates the beta-1 receptors. So the main action of this dobutamine is in the heart, because the main location of the presence of this beta-1 receptors is in the heart. So dobutamine, when it's given, it mainly prominently stimulates the beta-1 receptors that are present in the heart. And due to this, there is increase in heart rate, there is increase in cardiac contractility, and there is increase in cardiac output. But although it stimulates the beta-1 receptor that is present in the heart, there is no such major changes in the heart rate. That means there is no tachycardia. However, it increases the force of contraction of the heart as well as the cardiac output from the heart. However, it does not have major changes. It does not have change in the heart rate. It does not cause tachycardia. And although it is a derivative of the dopamine and it mimics the dopamine, it does not have a stimulation effect on the dopamine receptors. So dopamine acts on dopamine receptors, alpha receptors, and beta receptors depending on the dose. Whereas this dobutamine, which is the derivative of dopamine, although it mimics the dopamine, it does not have action on the dopamine receptors. So the major stimulation effect of this dobutamine is in the heart. It acts on the beta 1 receptors. So it increases the force of contraction in the heart. It increases the cardiac output from the heart, but it does not cause tachycardia. It does not have. It does not cause change in the heart rate. Okay, till now these were the drugs, this adrenaline, non-adrenaline, dopamine, dobutamine, or the isoprenaline. These were the drugs. They act in more than one receptors, may it be alpha receptors, beta receptors, or alpha receptor subtypes or beta receptor subtypes. So we do have some selective adrenergic agonists which act selectively on selective adrenergic receptors. As for example, the drug which have effect on only the alpha 1 receptors. So this includes the phenylephrine, ephedrine, so methoxamine, so mephentermine. So these are the group of drugs. So they are selectively, they have selective action on the alpha 1 receptors. And there are some drugs so which act selectively on alpha 2 receptors like clonidine, alpha methyl dopa, guanfacine, and guanabens. And some are the drugs which selectively acts only in the beta 2 receptors. And these drugs include the salbutamol, terbutaline, salmeterol, isoxaprine, and etodrine. So beta 2 adrenergic agonists are mainly used as a bronchodilator in the treatment of the bronchial asthma and the COPD because they do the bronchodilation effect. So they do have the bronchodilation effect. So we'll come on that. So these are the group of drugs which act selectively only on specific receptors, specific adrenergic receptors. And these adrenergic drugs can be also classified according to the therapeutic uses. As for example, pressure agents. So these pressure agents are the group of drugs which increases the blood pressure. That means their work towards the alpha 1 receptors is more because stimulation of alpha 1 receptors is mainly responsible for increasing blood pressure, to be more specific, diastolic blood pressure. So these are the group of drugs which mainly acts on the alpha 1 receptors of the blood vessels and increases the pressure. And obviously these drugs will be given in the patient who have low blood pressure. So the pressure agents include noradrenaline, ephedrine, dopamine, phenylephrine, and methoxamine. And these are the group of drugs which mainly acts in the alpha 1 receptors. And cardiac stimulants. So cardiac stimulants are the group of drugs which increases the heart rate, which increases the cardiac output, which increases the contraction of the heart. So they will be acting on the beta 1 receptors. As for example, adrenaline, dobutamine, and isoprenaline. And bronchodilator group of drugs. So bronchodilator group of drugs, they are mainly responsible for stimulating the beta 2 receptors in the lungs and causes the bronchodilation and can be used in the treatment and most commonly used in the treatment of bronchial asthma and COPD. As for example, isoprenaline, salbutamol, salmeterol, formoterol, bombuterol, and terbutaline. And we do have some nasal decongestant. So nasal congestion is also known as the stuffy nose, in which the blood vessels that is present in the nose become swollen and they are accumulated with the excess fluid and causing the patient to be stuffy nose or the blocked feeling. And this nasal congestion is usually present in the conditions like common cold, flu, or the sinus infection, in which the nasal blood vessels are swollen up and there is increase in nasal secretion, and usually the patient suffers from the runny nose. Now, what does this nasal decongestant do? They narrow the blood vessels that are present in the nose and they reduces the congestion, they reduces the swelling that is present in the nose. And this group of drugs are mainly associated to be stimulating the alpha 1 receptors. So nose consists of alpha 1 receptors which causes a vasoconstriction. So nasal decongestant are a group of drugs which dilate these blood vessels and are used as nasal decongestant. And the another adrenergic drugs include the CNS stimulants. So CNS stimulants means they will stimulate the CNS, and they are usually given in the patient, usually given in the children who are suffering from the condition known as attention deficit hyperkinetic disorder. And the children who are suffering from this disorder are usually the hyperkinetic child, and they have more problem of inability to concentrate for definite amount of time. And what does this group of drugs do? So they increases the attention span in those particular patients who are suffering from the attention deficit. And we do have the anorectic drug. So it is a dietary supplement or a drug which reduces the appetite and are more used in the patients who are suffering from the obesity, because these are the drugs which reduces the appetite in those particular patients. And this group of drugs include the fenfluramine, so sibutramine and dexfenfluramine. And the other adrenergic agonist or adrenergic drugs included are the uterine relaxants, and they are the group of drugs which relaxes the uterus. And the relaxation of uterus is mostly required in the patient, in the pregnant lady who are suffering from the threatened abortion. So threatened abortion, pregnant lady who is suffering from the threatened abortion, they have always chance of premature labor. There is always chance of abortion. And they are also used in the pregnant woman, so in which the labor has to be postponed or delivery has to be postponed. So delivery, postponing of this delivery is usually done in the cases where the fetus has not been matured, and they are also done in patient or the pregnant lady. So as for example, labor is there, labor pain is there, but you have that lady has been moved to hospital and there is no good facility, and she has to be reached in another hospital. So in that cases, we require the administration of the uterine relaxants. So they relaxes the uterus and inhibits the premature contraction of the uterus. So this group of drugs include the Ritalin, Isoprenaline, salbutamol, and terbutaline. So this finishes the adrenergic drugs, and adrenergic drugs important money. It's the adrenaline. So adrenaline uses its adverse effect, and obviously the correlation of this adrenaline with other catecholamines or non-catecholamines like non-adrenaline, dopamine, dobutamine, isoprenaline. And obviously the receptors, different adrenergic receptors, alpha receptors, beta receptors, its subtypes, and location, so major actions when these receptors are stimulated. Right? So we are moving towards the anti-adrenergic drugs. So anti-adrenergic drugs they are just opposite to that of the adrenergic drugs, and they are also known as sympatholytic drugs. So these are the group of drugs which blocks or decreases the effect of sympathetic nerve stimulation. They block or decrease the release of endogenous catecholamines, and they also block the action of the adrenergic drugs. So they are also known as the sympatholytic drugs. And since we do have the two different group of adrenergic receptors, so anti-adrenergic drugs or sympatholytic drugs are also of two types. So alpha receptors and the alpha blockers and the beta blockers, or alpha receptor blockers and the beta receptor blockers. So we are starting with the alpha blockers or alpha receptor blockers. So the classification of these alpha adrenergic blockers include non-equilibrium type phenoxybenzamine, so equilibrium type, which are non-selective, so consist of ergot alkaloids like ergotamine, ergotoxin, hydrogenated ergot alkaloids like dihydroergotamine, dihydroergotoxin, and imidazoline like phentolamine. And this non-equilibrium type, including the phenoxybenzamine, and equilibrium type, including this non-selective, including all these drugs are non-selective, and they are responsible for blockade of both alpha-1 as well as the alpha-2 receptors. And the group of drugs which only selectively blocks the alpha-1 receptors includes the prazosin, terazosin, doxazosin, alfedrosin, and tamsulosin. And the group of drugs which selectively blocks the alpha-2 receptors include the yohimbine. And we'll be discussing more about the alpha-1 selective blockers here in any section. So we are moving towards those drugs. So coming to the alpha blockers, this prazosin or this phenoxybenzamine and phentolamine are non-selective alpha blockers. They non-selectively blocks the alpha 1 and alpha 2 receptors. So they have non-specific action due to blockade of both these receptors and are not used that much. So usually alpha 1 selective blockers are most commonly used when alpha blockers has to be used. So coming to this alpha 1 selective blockers, so prazosin, so it is highly selective alpha 1 blocker and it is the first highly selective alpha 1 blocker. So it's responsible for blockade of alpha 1 receptors only. So when the alpha 1 receptor is stimulated, so there is vasoconstriction, there is increase in peripheral vascular resistance, and there will be increase in blood pressure. And so prazosin blocks these alpha 1 receptors, and hence it will block the constriction of the blood vessels. So that means it will cause the dilatation of the blood vessels, decreases the total peripheral resistance or the vascular peripheral resistance, and they decreases the blood pressure. So since they decreases the blood pressure, so the main use of this prazosin is in the hypertension or is in increased blood pressure. So main use of prazosin is in the treatment of the hypertension, that is the increased blood pressure. So it causes the blockade of the sympathetic vasoconstriction by blocking the alpha-1 receptors. And while giving prazosin, usually for the first time when prazosin is taken, a effect known as the first dose effect occurs, and it is manifested as the dizziness and fainting. So why this first dose effect occurs? Because first dose effect usually occurs in the patient who suddenly stands up from the lying down position. The person is in lying down position, and when that person suddenly stands up, so first dose effect occurs. And why does it more occurs with the prazosin? Because normally when the person stands up from the sitting position, so normally what is there? So there is a peripheral pulling of the blood due to the gravity. So due to the gravity, there is peripheral pulling of blood towards the legs, and so the blood that should be reached to the CNS will be less due to peripheral pulling of blood due to gravity. And when this alpha 1 blockers are being given, as for example prazosin, what does they do? They causes the vasodilatation. That means due to the vasodilatation, so now more of the blood will flow towards the legs when the person stands from the lying down position. So there will be more vasodilatation, and especially towards the legs, and the oxygen or the blood that should be raised towards the CNS will be less. And this is manifested as the dizziness and fainting. And usually this first dose effect occurs with the use of prazosin during the first time when prazosin is taken, and it usually disappears after the subsequent period of therapy. So first dose effect is important. It can be said as manifestation. It can be said as side effect due to the prazosin, and it is also known as postural hypotension or the orthostatic hypotension. So postural hypotension. Okay, we'll come on that. So coming to the uses of this prazosin, the main use of prazosin as an alpha blocker is in the treatment of hypertension, because they block the alpha 1 mediated vasoconstriction. So they are responsible for causing vasodilatation, decrease in peripheral vascular resistance, and decrease in blood pressure. So they are used in the treatment of the hypertension. And the second use of these alpha blockers or selective alpha 1 blockers include the Raynaud's disease. So Raynaud's disease is a peripheral vascular disease, and it is manifested as the discoloration of the extremities of the body. As for example, so here is the finger. So it is manifested as the discoloration of the extremities of the body, especially the fingers and the toes. So it is the finger, and from the white to bluish discoloration. And this Raynaud's phenomenon usually occurs due to the spasm, due to the contraction, or due to the constriction of the blood vessels that supplies these extremities. So due to the constriction or spasm of these blood vessels which supplies these toes or fingers, so obviously there will be decreased blood supply, decreased oxygen supply to this area. And as a result, so discoloration of the toes occurs, discoloration of the fingers occurs. The risk factors of this redness phenomenon includes the cold, exposure to the cold, or the emotional stress. So why these alpha-1 blockers are given in this Raynaud's disease or the peripheral vascular disease? So they blocks the alpha-1 mediated vasoconstriction. And you know, these alpha-1 receptors are mainly present in the smaller blood vessels, so which supplies the extremities. So obviously they will be present in the fingers, in the toes, and these alpha-1 blockers, so they inhibit the alpha-1 mediated vasoconstriction. They will cause the vasodilatation, and obviously the blood flow, the oxygen flow towards the toes, towards the fingers will be improved with the use of this alpha-1 receptor blockers. And another use of these alpha-1 blockers are the prazosin, selective alpha-1 blockers, in the treatment of the benign prostate hyperplasia. So benign prostate hyperplasia occurs in the male. So it only occurs in the males, not in female, and male too that crosses the 40 or 50 years of the age. And with the age, there is increase in the prostate mass, there is increase in size of the prostate, and usually the condition is the benign, it's not the malignant, and there is the increase in mass of the prostate. So due to the increase in mass of the prostate in the this benign prostate hyperplasia, so there is the constriction of the ureter. So the ureter, due to the increase in size of this prostate, there is constriction of the ureter. So due to the constriction of the ureter, so there is difficulty in micturition, there is difficulty in voiding in these patients who are suffering from the benign prostate hyperplasia. So these alpha-1 blockers, why they are given? So the tone of urethral sphincter and prostate is reduced by the blockade of alpha-1 receptors. So due to this increase in size, increase in mass of this prostate, so the sphincters are usually constricted, they are usually contracted, and there is difficulty in voiding, there is difficulty in micturition. So due to increase in size of the prostate, the sphincters are constricted, the ureter is constricted. And why this alpha-1 blocker is given? Because it causes the relaxation of these sphincters that are present on the urinary bladder, and now they will improve the urine flow in those particular patients who are suffering from BPH. So tone of the urethral sphincter and prostate is reduced. That means the sphincters that are present on the urinary bladder will be relaxed due to blockade of the alpha-1 receptors, and urine flow in those patients is improved. So these are the main uses of this alpha-1 blockers, selective alpha-1 blockers in the treatment of hypertension, peripheral vascular disease or Raynaud's disease or phenomenon, and benign prostate hyperplasia. And adverse effect of these alpha-1 blockers include the forced dose effect. So as said earlier, so when prazosin is given in these patients who are suffering from hypertension, so main use of this prazosin is in treatment of hypertension. So it causes the first dose effect. That means while from standing position, when the patient stands up from the lying down position, so there is a peripheral pulling of blood due to gravity, and due to use of prazosin, so since there is more vasodilation, more blood will be pulled towards the legs, and CNS will be deprived of excess and CNS will be deprived of the needed amount of the blood, needed amount of the oxygen. So there will be the fainting effect in those patients. So this is the first dose effect, and usually they are this disappears on the subsequent use of this prazosin or alpha-1 blockers. And this is also known as, this first dose effect is also known as orthostatic hypotension or the postural hypotension. That means the hypotension or decrease in blood pressure that changes with the posture. So if this occurs, it's also known as the orthostatic hypotension or the postural hypotension, which is manifested as dizziness, lack of energy and headache, and it is due to the same condition the CNS becomes deprived of the necessary amount of the blood, necessary amount of the oxygen. And the another adverse effect related to the use of this prazosin is it causes the blocking of alpha-1 receptors in the ejaculatory duct. So ejaculatory duct consists of the alpha-1 receptors, and normally stimulation of this alpha-1 receptors in this ejaculatory duct will cause the ejaculation. Whereas when we are giving these alpha-1 blockers, they will block the alpha-1 receptors that are present in the ejaculatory duct, and they will cause the inhibition of the ejaculation, and this will lead to the ejaculatory dysfunction. And since these are the group of anti-adrenergic drug, and alpha-1 receptors are present in the muscle of the iris, that is the radial muscle or the dilator pupillae. So they will cause the relaxation of this dilator pupillae. They will cause the relaxation of this radial muscle and will lead to the meiosis or the constriction of the pupil. So don't get confused if meiosis and mydriasis is being asked. So meiosis is caused by the use of two different group of drugs in this ANS system, drugs included in ANS. So meiosis is caused by the cholinergic drug. Meiosis is also caused by these anti-adrenergic drugs, especially the alpha blockers. And mydriasis is caused by the anticholinergic drug, and mydriasis is also caused by another group of drugs that are included in ANS, which include the adrenergic drug. So, but however, different group of muscles is involved in meiosis and in this meiosis and mydriasis, and they are caused by the relaxation or the contraction of different muscles in the that are included in the muscle of the iris. So coming to other alpha blockers apart from the prazosin. So prazosin is a prototype drug in the alpha-1 selective alpha-1 blockers. So other alpha-1 blockers include the terazosin and tamsulosin. So terazosin is similar to prazosin, but they do have the better bioavailability, and the duration of action of this terazosin is longer, that is 24 hours. And they are the drug which are more preferred in benign prostate hyperplasia than that of the prazosin. And we do have the tamsulosin. So tamsulosin is uroselective. And when coming to alpha-1 receptors, so you know the different subtypes of alpha receptors, alpha-1 and alpha-2. But alpha-1 receptors, Mapani, they do have another subtypes, right? So alpha-1 receptors, Mapani, alpha-1A, alpha-1D, alpha-1B. So alpha-1B is mainly present in the blood vessels. This is detail masaina. So alpha-1B is present mainly in the blood vessels, whereas alpha-1A and alpha-1D are mainly present in the urinary bladder. And these tamsulosin are more uroselective, and they are the drug which do not cause change in the blood pressure and heart rate at therapeutic dose, because it is not tamsulosin does not act on the alpha-1B receptors. So alpha-1B receptors are present mainly in the blood vessels. The stimulation of those alpha-1B receptors is responsible for increasing blood pressure by vasoconstriction. So since it does not act on the alpha-1B receptors that are present in the blood vessels, there is no change in the blood pressure and heart rate at the therapeutic doses, and they are more preferred among all the alpha-1 blockers. Selective alpha-1 blockers, tamsulosin is most commonly used drug and preferred drug in the treatment of BPS, because they don't have any effect on the alpha-1B receptors, and hence they do not have any change in the, they do not cause any change in the blood pressure. So the patient who are suffering from the benign prostate hyperplasia, but they don't have hypertension, then tamsulosin is most commonly preferred. So now coming to the beta-adrenergic blockers. So beta-adrenergic blockers are obviously, they are the group of drugs. They will inhibit or they will block the beta receptors. So most important beta receptors include the beta-1 and beta-2. So group of drugs which selectively blocks the beta-1 receptors, which is also known as cardioselective beta blockers, because beta-1 receptors are mainly present in the cardiac cells, in the heart cells. So selective beta-1 blockers are also known as a cardioselective beta blockers. So they include the drugs such as metoprolol, atenolol, acebutolol, bisoprolol, esmolol, betazolol, celiprolol, and nebivolol. And the group of beta-adrenergic blockers which non-selectively blocks both beta-1 and beta-2 receptors include the two group of drugs, So these are non-selective beta blockers are the group of drugs which non-selective blocks both beta 1 receptors as well as the beta 2 receptors. So without the drug, without intrinsic sympathomimetic activity, include the propranolol, sotalol, and timolol, and the drug with intrinsic sympathomimetic activity include the pindolol, acebutolol, and oxprenolol. So what is this intrinsic sympathomimetic activity? So these are the group of drugs which have partial agonistic action. So intrinsic sympathomimetic mimetic activity, the drugs which falls under this group of drugs are the group of drugs which have partial agonistic activity. That means in the presence of agonist, they will act as antagonist, and in the presence of antagonist, they will be acting as agonist. And this also includes drugs without intrinsic sympathomimetic activity. That means they don't have any partial agonistic activity. So non-selective beta blockers are the group of drugs which non-selective blocks both beta 1 as well as beta 2 receptors, and they may be further classified as drugs with intrinsic sympathomimetic activity and the drugs without intrinsic sympathomimetic activity. And we do have another group of beta blockers which do have the additional alpha blocking activity as well. So apart from blocking beta receptors, they also block the alpha receptors. And this group of drugs include the labetalol, cardivolol, and celiprolol. So these blocks the beta receptors along with the alpha receptors. So now we are going towards the beta adrenergic blockers, and among all these beta adrenergic blockers, this propranolol, which is non-selective beta blockers, which non-selective blocks beta 1 as well as beta 2 receptors, are the prototype drug in the beta adrenergic blockers. So beta adrenergic blocks means propranolol is the prototype drug. So now coming to the pharmacological actions of this propranolol. So because it will block both beta 1 and beta receptors, so the pharmacological actions will be blockade of both the beta 1 as well as the beta 2 receptors. So in the heart, so stimulation in the heart, what does it do? So it increases the heart rate, it increases the cardiac output, it increases the force of contraction. While we are giving propranolol, they will block all these activities and will cause opposite function. That means it will decrease the heart rate, it will decrease the cardiac output, it will decrease the force of contraction of the heart. And since heart rate is decreased, since force of contraction is decreased, so cardiac work that should be done by heart is also decreased. And since heart rate is decreased and decrease in force of contraction of heart is there, oxygen consumption by the heart is also reduced. So in the blood pressure, so what's the effect of this beta blockers or the propranolol in the blood pressure? So, this beta adrenergic blockers, while going through beta adrenergic blockers or the propranolol, which non-selective blocks beta 1 as well as beta 2 receptors. And, this beta receptors normally consist of the beta 1 and beta 2 receptors. So beta 1 receptor stimulation will increase the heart rate, will increase the cardiac contraction, will increase the cardiac output. And stimulation of beta 2 receptors in the blood vessel will lead to the vasodilatation, will lead to the decrease in total peripheral resistance or vascular resistance. And while you give propranolol, so since being the non-selective beta blocker, so it will block both the beta 1 as well as the beta 2 receptors. So blockade of beta 1 receptors and blockade of beta 2 receptors will be opposite to that of the stimulation. So blockade of beta 1 receptors will decrease the cardiac output. Whereas the blockade of beta 2 receptors, what does they do when we are using propranolol? So what does it do? So it will have the opposite effect to that of vasodilatation, that is a vasoconstriction. And it will also, vasoconstriction will lead to the increase in total peripheral resistance. So the use of this propranolol, so the main use of propranolol is in the use of, they are used in treating the hypertension or increased blood pressure. But what you can see here is due to blockade of this beta 2 receptors with the use of propranolol, it has caused vasoconstriction and it has increased the total peripheral resistance, which will be increasing now blood pressure. So you are giving this drug for the treatment of blood pressure and it's increasing the total peripheral resistance, it's causing the vasoconstriction, it's increasing the blood pressure. So how this propranolol can be given in the treatment or for the treatment of blood pressure? So this makes a bit contradiction to the use of propranolol in the treatment of hypertension, but on the long-term administration of this propranolol or non-selective beta blockers, blood vessels adapt chronically to low cardiac output. So blockade of this beta 1 receptors will also decrease the cardiac output. So normally per minute मा चाहिने 1000 ml blood चाहिने suppose the normally 1000 ml blood चाहिने हार्टबाट पम्प भएर बाहिर निस्किराखेको थियो decrease in cardiac output ले के हुन्छ त भन्दाखेरि चाहिँ नि त्यो भोल्युम चाहिँ रिड्युस गर्छ as for example 1000 बाट चाहिँ 700 800 ml चाहिने अब per minute चाहिँ हार्टबाट चाहिँ पम्प भएर बाहिर निस्किन्छ. So on long term administration of these beta blockers or propranolol, blood vessels adapt to chronically low cardiac output. The decrease in cardiac output will lead to decrease in total peripheral resistance. As for example, कुनै पनि blood vessels बाट cardiac output जस्तो 500 ml blood चाहिने निस्किरहेछ or flow भइरहेछ कुनै पनि blood मा भने blood vessel मा. So if this cardiac output has been reduced and this 500 ml of blood has been reduced to 300 ml of blood, so के हुन्छ त भन्दाखेरि चाहिँ 500 ml of blood through to pass. So for passing of this 500 ml of blood through that particular blood vessels, so के हुन्छ त arteriesहरूले more work गर्नुपर्ने हुन्छ. So there will be increase in peripheral vascular resistance, but cardiac output reduce भइराखेको छ due to the use of this non-selective beta blockers. So 500 को ठाउँमा अब 300 ml of drug चाहिने of this blood चाहिने through that particular blood vessel pass गर्दाखेरि के हुन्छ त भन्दाखेरि चाहिँ 500 ml has been reduced to 300 ml. So now less work has to be done by the arteries, and less work has to be done by arteries means there will be less resistance. So there will be decrease in total peripheral resistance, and decrease in total peripheral resistance will decrease in pressure in the arteries, and now decrease in pressure in the arteries will lead to the decrease in blood pressure. So I'll repeat this once again. So the use of this propranolol is in the treatment of hypertension, and this is the main most commonly used therapeutic indications for propranolol. But so there is two main receptors in the beta 1 receptors, so beta 1 and beta 2. So beta 1 normally it increases the heart rate, it increases the cardiac contraction, it increases the cardiac output, and beta 2 receptors stimulate हुँदाखेरि चाहिने. So normally so vasodilation हुन्छ, decrease in total peripheral resistance, decrease in blood pressure हुन्छ. And when you are giving the beta blockers, non-selective beta blockers, so all the things will be opposite. That means it will cause the blockade of beta 1 receptors, will decrease in cardiac output, and similarly beta 2 receptors blockade हुँदाखेरि there will be vasoconstriction, there will be increase in total peripheral resistance, and there will be increase in blood pressure. But this propranolol is used in the treatment of the hypertension, and this rationale makes a bit contradiction for the use of this propranolol in the treatment of hypertension, because when you are giving propranolol, it will cause the vasoconstriction, increase in TPR, and will cause increase in blood pressure. So there is a little bit contradiction. But when this propranolol is being used for long time, so this will decrease the cardiac output as well. So decrease in cardiac output means there will be decrease in blood release, blood pump from the heart, and there will be decrease in blood flow towards the respective peripheral arteries or respective peripheral blood vessels. So normally 500 ml of blood pass भइराखेको थियो भने अब beta blockers, when you're giving for long time, since cardiac output has been reduced, as for example 500 थियो भने अब 300 ml हुन सक्छ. So 300 ml flow हुनु भनेको कुनै particular vessel मा from the 500 to 300. So less work has to be done by that respective arteries, and less resistance will be there to flow the blood, and there will be decrease in total peripheral resistance, there will be decrease in work done by the arteries, there will be decrease in pressure in the artery, and this will now subsequently lead to decrease in blood pressure. But त्यसको लागि this beta blockers or the propranolol or non-selective beta blockers has to be used for long term and after the long-term administration only, this the work of this propranolol in the treatment of hypertension is beneficial or can be seen. So blood pressure, there's no, as said earlier, there's no direct and acute action on the blood pressure. So एकचोटि खायो दुईचोटि खायो or एक हप्तालाई खायो 15 दिनलाई खायो भने decrease in blood pressure हुँदैन. But beneficial effect is seen in this hypertensive patient on prolonged administration. And normally, so when we give propranolol, what does it do? It blocks the catecholamine-induced vasodilatation. So normally, catecholamine-ले vasodilatation गरिराखेको हुन्छ, decrease in PPR गरिराखेको हुन्छ. But when you are giving propranolol, they block the catecholamine-induced vasodilatation and will cause increase in total peripheral resistance and will cause decrease in cardiac output as well. But they will cause negligible change in blood pressure. So on long-term use, so blood vessels will cause the adaptation, will adapt. But chronic exposure of this propranolol will lead the resistance vessels means arteries, so will lead the resistance vessels to adapt to chronically low cardiac output, and due to this total peripheral resistance was, and this is the most possible explanation for the hypertensive effect of propranolol. So other explanation why this propranolol is used in the treatment of hypertension may be, so they causes the decreased release of renin from the juxtaglomerular cells of the kidneys, and also they causes the decrease in central reduction of sympathetic outflow. The central reduction of sympathetic outflow means there will be less of the non-adrenaline or adrenaline flow, and less adrenaline, non-adrenaline means there would be decrease in blood pressure. So decrease in renin release. So you know this renin is being released from the juxtaglomerular cells of the kidney, and what does it do? It causes the conversion of I think +2 मा पनि हुन्छ है. So this is just the revision. And renin, what does it do? It causes the conversion of angiotensinogen to angiotensin 1. And the lungs has got the angiotensin converting enzyme which converts the angiotensin 1 to angiotensin 2. And angiotensin 2 causes the adrenal gland to release the aldosterone. The aldosterone, what does it do? It does different functions. It acts on the arteries and causes the vasoconstriction and lead to the increase in BP. Whereas the renin has direct action on the increase in sodium and salt retention from the kidney. So increase in sodium and water inside the blood will cause the increase in blood pressure. So what does this beta blockers do? So renin at all, so overall what does it do? It causes the formation, or it causes the release of aldosterone from the adrenal gland and will cause the vasoconstriction in the blood vessels and will cause increase in blood pressure. So it will also cause the sodium and water retention. The renin directly causes sodium and water retention, which all lead to the increase in blood pressure. So we are using the beta blockers. So beta blockers, what does it do? It decreases, since renin release is associated with the stimulation of beta-1 receptors present in the Golgi cells of the kidney. So renin release is blocked down. So renin release blocked down or inhibited भनेको चाहिँ नि, this all process will not be there, and there will be now decrease in BP. So decrease in renin release from the kidney by the use of beta blockers is another possible explanation of this propranolol to be used in the hypertension. So now going to the other pharmacological actions of these non-selective beta blockers. So in the respiratory tract, so usually stimulation of this beta-2 blockers that are present in the bronchioles of the lungs will cause the bronchodilation. Whereas you are giving the beta blockers, so it will block this beta-2 mediated bronchodilation. That means now there will be the bronchoconstriction. So bronchoconstriction will be there, and this occurs as a result of blockade of beta-2 receptors that are present in the bronchioles. And hence the use of this non-selective beta blockers. So remember, the use of this non-selective beta blockers which block both beta-1 and beta-2 receptors, if they are used in hypertension and the same patient is suffering from the asthma, that could be dangerous, because asthma ma चाहिँ usually के गरिरा asthma ma bronchoconstriction हुन्छ, So bronchoconstriction जुन भइरहेको हुन्छ आजमामा त्यो चाहिँ डाइलेट गर्नुपर्ने हुन्छ, bronchodilation गर्नुपर्ने हुन्छ. But what you are doing with the use of propranolol, you are further exaggerating the bronchoconstriction by using the propranolol. So it's very dangerous if these non-selective beta blockers are used in the patient who are suffering from the bronchial asthma. This the patient if the patient is asthmatic and if the patient is hypertensive as well, and beta blockers, if beta blockers need to be used in those particular patients, त्यस्तो केसेसमा we need to use the cardio selective beta blockers, right? So I hope you are following me. So in those patients who are suffering from the bronchial asthma, and if the same patient is suffering from the hypertension, and there are other group of hypertensive drugs as well. So सबभन्दा राम्रो other group of hypertensive drugs चाहिँ त्यो पेशेन्टलाई दिने. And if beta blockers नै युज गर्नुपर्छ भने चाहिँ नन सेलेक्टिभ beta blockers चाहिँ नि युज नगर्ने है, किनभने आजमामा already there is bronchoconstriction हुन्छ. So when you are giving non selective beta blockers, you are inhibiting or you are further exaggerating the bronchoconstriction by blocking the beta 2 receptors that are present in the bronchioles. So that means you are exaggerating the condition. So in that case, you need to use the cardioselective beta blockers, which only blocks the heart or which only blocks the cardiac cells. They don't have any effect on constricting the bronchioles in the lungs. So in that case, beta-1 selective drugs are preferred. And in the eye, so it decreases the intraocular pressure. So one of the drugs that I use in the treatment of glaucoma is the beta blockers as well. So they decreases the intraocular pressure by reducing the production of the aqueous humor. So this aqueous humor is produced by the ciliary epithelium, and the ciliary epithelium consists of the beta 2 receptors. So stimulation of beta 2 receptors in the ciliary epithelium is responsible for production of more of the aqueous humor, which can increase the intraocular pressure. So you are giving beta blockers, so you are blocking the beta 2 receptors in the ciliary body epithelium. That means you are now decreasing the formation of the aqueous humor, so that now the increased IOP in the glaucoma can be decreased with the use of beta blockers. And in the skeletal muscle, the stimulation of beta 2 receptors in the muscle usually cause tremors, increasing contraction of the skeletal muscle. Whereas beta blockers, we are talking about the beta blockers, so they will have the opposite effect. So they can be used in the reduction of the tremors, which is a pathological condition. So they causes the beta 2 receptors that are present in the skeletal muscles to be blocked, and they reduces the tremors. And when you are using beta blockers, they also reduces the exercise capacity in the patient. So what does it do when you are using beta blockers? So what does it do? So it also blocks the beta 2 receptors in the blood vessels. So blockade of beta 2 receptors means there will be no vasodilatation, there will be vasoconstriction. So exercise ko belama aj ke huncha, there will be need of more of the blood. The blood vessels need to be dilated. So it causes the vasoconstriction. So there will be the reduced blood flow towards the peripheral arteries or peripheral blood vessels. Only this will lead to the reduction in the exercise capacity. And reduction in exercise capacity is also due to the glycogenolysis and inhibition of glycogenolysis and lipolysis, or reduction of glycogenolysis and lipolysis. So normally when beta receptors are stimulated, they will cause the glycogenolysis and lipolysis and will increase the level of the glucose, blood glucose level. But when you are using beta blockers, there will be reduction, there will be inhibition of glycogenolysis and lipolysis, there will be decrease in glucose. But exercise ko belama like science also body glucose science, because you're inhibiting glycogenolysis and lipolysis, there will be less amount of the glucose, and there will be, this will lead to the reduction in exercise capacity. Okay, so there is one phenomenon known as Dale's vasomotor phenomenon. So tomorrow we'll be discussing about the uses and adverse reaction of this beta blockers. So before that, for now, so there is a one phenomenon known as Dale's vasomotor phenomenon, which was discovered by the Sir Henry Dale, and what he invented was, so when adrenaline is given, so adrenaline is the neurotransmitter, it is a drug, so which stimulates both alpha and beta receptors. So when there is high concentration of adrenaline, what does it do? So it stimulates first the alpha receptors. So alpha receptors, stimulation of alpha 1 receptors will cause the vasoconstriction and will lead to the increase in BP. So this is the effect of adrenaline in the blood pressure. Okay, so this figure shows the effect of adrenaline on the blood pressure. So when adrenaline is given and so when adrenaline is given on the high dose, when the higher concentration of adrenaline is present and when it's given intravenously, so first of all, it will stimulate the alpha 1 receptors. So stimulation of alpha 1 receptors means there will be increased in blood pressure due to increase in vasoconstriction, due to increase in total peripheral resistance. And when now when there is when the concentration of this adrenaline decreases, so concentration of adrenaline decrease भएपछि अब केलाई इफेक्ट गर्छ, कुन रिसेप्टर्सलाई इफेक्ट गर्छ? So it is the beta 2 receptors, and you know what is the action of beta 2 receptors when they are stimulated. So beta 2 receptors stimulation, they decreases the blood pressure by the vasodilation, by fall in total peripheral vascular resistance. So initially it increases the blood pressure due to alpha 1 effect, and when the concentration falls, it decreases the blood pressure due to action on the beta 2 effect. And this effect of adrenaline is known as biphasic response on BP. Okay, so this effect on adrenaline is known as biphasic response on blood pressure. And now, so what is this vasomotor phenomenon? So when you give now alpha blocker, so alpha blocker you give the alpha blocker, and now this alpha blocker, administration of alpha blocker is followed by administration of adrenaline. There will be only fall in BP. So why there is only fall in BP? Because you have blocked the alpha blocker. As for example, you are giving prazosin. So you are what you are doing, you are blocking the alpha 1 receptors. You are blocking the alpha 1 receptors means, so alpha 1 receptors normally vasoconstriction गरेर जुन increase in BP गराइराखेको थियो त्यो चाहिँ के हुन्छ, block हुन्छ. Now there will be only effect of the beta 2 action. So there will be only beta 2 action. So you know what's the action of beta 2 on blood vessels. So it causes the fall in BP. So due to decrease in total peripheral vascular resistance, and it is due to the vasodilatation. So this vasomotor phenomenon you give the adrenaline, so biphasic response of adrenaline on blood pressure is seen. That is followed by the administration of alpha blockers. So alpha blocker alpha blockers, which causes the vasoconstriction, is now blocked, and you give the adrenaline. So since alpha receptors has been blocked, so adrenaline alpha receptors ma काम गर्न पाएन. अब के हुने भयो त, beta 2 effect only देखियो blood pressure मा. That means it will now only cause the vasodilatation, decrease in total vascular resistance, and decrease in BP. And this is known as the Dill's vasomotor phenomenon. अनि यो चाहिँ especially यो भाइभाहरुमा चाहिँ सोधिराखेको हुन्छ Dill's vasomotor phenomenon. So I think the time is off now, and before signing off for today, so I've already sent this thing in Aditya's mail. Right? So these are the practical questions that is need to be carried out and that need to be solved in ANS section. It's in different categories. So ANS ma, so we do have the graph section. So we do have 4 graphs. So identification of catecholamines, interpretation of these all the graphs, and clinical problems. Clinical problems, we do have 4 questions over here. 4 questions over here, and we do have the drug profile. So drug profile ma, all the drugs until now we have carried in ANS are included, and important drugs. And this much as for example, generic name, therapeutic group, similar drugs, mechanism of action, indications or therapeutic uses, adverse effect, if there is any contraindication, if there is any drug interaction. So rationale of combination, as for example, I'm LA with the local anesthesia with adrenaline, just the so antidote, if poisoning occurs or overdose occurs, so if there is any presence of antidote, all should be written down, and we do have the 4 prescription as well. So you survey when you come to the next class, so as the possible so when you come after this weekend, maybe Sunday or Monday, so please solve all these questions. So if you have logbook, please try to solve in your logbook. And if not, you can do in rock papers, and it will be good if you can do it in PowerPoint and present it. So after we are complete with anti-adrenergic drugs, so we'll be going to discuss all these clinical cases, prescription graphs, right? So I request you to solve all the questions, and I'll choose you randomly and make you to answer. Okay?
Okay, ma'am.
Reduced by use of alpha blocker. When BP is reduced by use of alpha blocker, will BP restore to normal after some time? Then extra drug will be required. So BP reduce, हामीले BP reduce कुन केसमा गर्नुपर्छ भन्दाखेरि नि, in the case of hypertension. So hypertensionलाई हामीले चाहिँ increased blood pressureलाई हामीले चाहिँ नि normally hypertension भनेर भन्छ हैन. Hypertensionको छुट्टै chapter in detail will be taken in your CNS section in first year only. सो हामीले बीपीको लागि बीपी रिड्युस गर्नको लागि चाहिँ अल्फा ब्लकर दिइरहेको छ, एज फर एक्जाम्पल प्राजोसिन हैन. सो विल ब्लड प्रेसर रिस्टोर टु नर्मल आफ्टर सम टाइम और एनी ड्रग. सो बीपी हामीले चाहिँ नर्मली अल्फा ब्लकर दिनु और बीटा ब्लकर दिनु, अरू ग्रुप अफ ड्रग दिनु बीपी रिड्युस गर्नलाई नै हो इन केस अफ हाइपरटेन्सन. So any drug is not required, any additional drug is not required to restore the blood pressure, because we are giving the drugs to decrease the BP. So any drug is not required, and normal the BP will be restored to normal चाहिँ हुँदैन. So it will normal भन्दा normal or it will be reduced, right? So normal मा चाहिँ restore गर्नलाई or reduce गर्नलाई हामीले चाहिँ alpha blockers, beta blockers or any group of drugs is given, but no extra drugs is required to restore that BP. Any other question? Why propranolol is used in migraine? So we'll be coming on that tomorrow. We have not gone through the indications of propranolol. Any other question? So if not, we'll be signing off for today.